Hypertrophic cardiomyopathy is an cardiovascular disease. Look at this picture, shows that ECG findings, cardiac MRI findings. Look at this. And echocardiogram findings. Look at this. A detail going on. Introduction. Hypertrophic cardiomyopathy, HCM, is a complex and heterogeneous cardiac disorder characterized by abnormal thickening of the heart muscle, primarily the left ventricle. The condition affects the heart's ability to pump blood efficiently and may lead to significant complications including arrhythmias and sudden cardiac death. HCM is a significant cause of morbidity and mortality, particularly in young individuals and athletes. Etymology. The term hypertrophic cardiomyopathy derived from Greek roots. Hypertrophic combines hyper meaning over or excessive and trophy meaning nourishment or growth. Indicating excessive growth of the heart muscle. Cardiomyopathy fuses cardia meaning heart with myo meaning muscle and pathy meaning disease. Refers to a disorder of the heart muscle. Definition. Hypertrophic cardiomyopathy is defined as a genetic disorder of the myocardium characterized by unexplained left ventricular hypertrophy in the absence of conditions that can cause secondary hypertrophy such as hypertension or aortic stenosis. Types. 1. Obstructive HCM. The thickened heart muscle obstructs blood flow out of the left ventricle, often referred to as hypertrophic obstructive cardiomyopathy, HOCM. 2. Non-obstructive HCM. There is no significant obstruction to blood flow, but the thickened muscle impair the heart ability to fill properly. 3. Apical HCM. Hypertrophy is localized to the apex of the heart. A mild ventricular HCM thickening occurs in the mid portion of the left ventricle, sometimes causing mid cavity obstruction. 5 other forms: diffuse hypertrophy without a predominant area of involvement. Causes: HCM is primarily caused by mutations in genes encoding sarcomeric proteins. These mutations are inherited in an autosomal dominant pattern, although de novo mutations can also occur. Key genes include 1. MYH7 beta myosin heavy chain, 2. MYBPC3 myosin binding protein C, 3. TNNT2 trophoin T. Risk factors: 1. Genetic predisposition, family history of HCM. 2. Age. Symptoms often manifest in adolescence or elderly adulthood. 3. Physical activity. Intense exercise can unmask symptoms in predisposed individuals. 4. Gender. Males are slightly more affected than females. 5. Comorbid conditions: hypertension and diabetes may exacerbate symptoms. Complications: 1. Arrhythmias, atrial fibrillation, ventricular tachycardia, or fibrillation. 2. Heart failure due to diastolic dysfunction or obstruction. 3. Sudden cardiac death, particularly in young athletics. 4. Stroke, often suddenly to atrial fibrillation. 5. Mitral regurgitation, resulting from obstruction or abnormal leaflet movement. Pathophysiology, hypertrophic cardiomyopathy is a genetic cardiac disorder characterized by abnormal thickening of the myocardium, primarily affecting the left ventricle. Below is a step-by-step outline of its pathophysiological process. 1. Genetic mutation. 2. Myocardial hypertrophy. Hypertrophy development, asymmetry, microscopic changes. 3. Left ventricular outflow tract, LVOT, obstruction. Anatomic abnormality, dynamic obstruction. 4. Diastolic dysfunction, impaired relaxation, increased filling processes. 5. Ischemia, mismatched oxygen demand and supply, increased demand, reduced supply. 6. Electrical instability, disorganized myositis, risk of arrhythmias. 7. Heart failure progression, preserved ejection fraction, EF. Initially, EF is preserved or increased, but diastolic dysfunction limits cardiac output. Heart failure symptoms over time, LV systolic function may decline, leading to heart failure symptoms such as dyspnea, fatigue, and exercise intolerance. 8. Complications, sudden cardiac death, SCD, due to ventricular arrhythmias, particularly in young individuals. Arterial fibrillation, AF, due to increased arterial pressure and remodeling. Thromboembolism, stroke risk increases with AF. Heart failure, progression to advanced heart failure in some patients. Signs and symptoms. 1. Dyspnea, most common symptom due to diastolic dysfunction. 2. Chest pain, exhaustion, angina. 3. Palpitations from arrhythmias. 4. Syncope, often exhaustional due to obstruction or arrhythmias. 5. Fatigue from decreased cardiac output. 6. Sudden cardiac arrest in severe cases. Diagnosis: 1. History and physical examination, family history of HCM or sudden cardiac death, murmur heart or auscultation often intensified with Valsalva maneuver. 2. Diagnostic tests. Electrocardiogram ECG shows LVH, STT wave changes and arrhythmias. Echocardiography, key imaging modality to confirm hypertrophy and obstruction. Cardiac MRI provides detailed imaging of myocardial structure and fibrosis. Genetic testing identifies causative mutations. Holter monitoring detects arrhythmias. Stress testing elevates exercise tolerance and obstruction. Nursing diagnosis: 1. Decreased cardiac output related to left ventricular obstruction or diastolic dysfunction. 2. Activity intolerance related to reduced oxygen supply and cardiac output. 3. Risk for ineffective tissue perfusion related to arrhythmias or obstruction. 4. Fear, anxiety related to potential for sudden cardiac death. 5. Knowledge deficit about disease and management. Management: first, medical management. A. Pharmacological. 1. Beta blockers reduce heart rate and myocardial oxygen demand. 2. Calcium channel blockers improve diastolic function. 3. Antiarrhythmics control arrhythmias. 4. Anticoagulants for patients with atrial fibrillation. B. Invasive procedures. 1. Spectral myosectomy surgical removal of hypertrophic spectrum. 2. Alcohol septal ablation induced localized myocardial infarction to reduce obstruction. 2. Implantable cardioverter defibrillation prevents sudden cardiac death. C. Lifestyle modifications avoid intense physical activity, maintain hydration, monitor symptoms regularly. Nursing management: 1. Monitor vital signs, particularly heart rate and blood pressure. to educate the patient on medication adherence, activity restrictions, and symptom monitoring. 3. Psychosocial support address anxiety and fear related to the condition. 4. Prevent complications, recognize early signs of arrhythmias and obstruction. 5. Coordination of care, collaborative with multidisciplinary teams for comprehensive management. Treatment options: 1. Medications, beta blockers, calcium channel blockers, and antiarrhythmics. 2. Surgical interventions, spatial mastectomy, alcohol ablation. 3. Device implantation, ICD for high risk patients. 4. Lifestyle modifications tailored to individual needs. 5. Cardiac rehabilitation enhances physical and emotional recovery. Psychosocial medicine: 1. Counseling for coping with chronic illness. 2. Support groups connecting patients and families with similar experiences. 3. Stress management techniques such as mindfulness or relaxation exercises. 4. Education empower patients with knowledge about their condition. 5. Family involvement engaging family members in care and decision making. Prevention: 1. Genetic screening for at risk family members. 2. Lifestyle modifications avoiding high intensity sports. 3. Routine monitoring early detection of progression or complications. 4. Risk stratification identifying individuals at risk of sudden cardiac death. 5. Public awareness educating communities about HCM. In conclusion, hypertrophic cardiomyopathy is a multifactored condition with significant implications for affected individuals. Early diagnosis, tailored management, and comprehensive care, including psychosocial support, are essential to improve outcomes. Advances in genetic research and therapeutic strategies offer hope for better understanding and management of this complex disease. Thank you. Have a nice day.